All right, everyone. Good afternoon, and thank you for being here today. Hope your neutrophils are in the right place because we have a very interesting case for you today and repercussions from the case. Our speakers today, the presenter of the clinical case is our own pediatrics resident, Dr. Kristen Mikhail, one of our second-year pediatrics residents that is gonna pursue a career and a fellowship in allergy immunology, which excites us a lot. And then as our senior faculty speaker, we have Dr. Lauren Merz, an hematology fellow at Dana-Farber Cancer Institute at Mass General Brigham and Harvard. Hey, for Harvard, for recent reasons for sure. In Boston, Massachusetts, and she'll be talking about a topic after we talk about the case as well. So, Kristen, you can take it over.
All right, so I'll start off presenting a case prior to our expert speaker, and I'll present a case on neutropenia without recurrent infections. Try to get this to here. All right, so the learning objectives for today will be to identify the need for further workup of neutropenia based on a complete history and to recognize individuals who may have typical neutrophil counts outside of standardized normal ranges when determining the need for further workup. So we present the case of a 24-year-old otherwise healthy male with neutropenia without infections. This patient, prior to presentation, he was seen out of state for a PCP visit where routine screening CBC showed leukopenia and neutropenia with a white blood cell count of 3.2 and an ANC of 467. He was then followed by his PCP with similar rechecks until he moved out of state. So he then established care with a new PCP here and did not have any active concerns at the time. His full past medical history, it includes anxiety and depression that's well controlled on medication, a new ADHD diagnosis that's pending follow-up for medication and counseling. When he was out of state, he was noted to have elevated transaminase levels in the setting of an elevated CK. This was after a period of robust exercise. He did have a mildly positive ANA at that time and had an overall reassuring rheumatologic workup and ended up having resolved transaminases. He also has an atopic history with environmental and food allergy. Regarding his past surgical history, it's just pertinent for dental surgery. He currently takes an SSRI daily and an antihistamine as needed. He is overall up to date on his immunizations, except for the HPV vaccine. His family history is significant for a mother that has neutropenia without significant infections. No genetic testing was done or any immune or further workup for her. This patient is of Middle Eastern descent. He does not have a family history of immunodeficiency or other rheumatologic conditions, and he does have one brother who is healthy. He recently moved here for graduate school. He lives with 2 roommates. His overall review of systems and physical exam was unremarkable. No hepatosplenomegaly, lymphadenopathy, bruising, rashes, or any other focality on his exam. The plan from his PCP at this point regarding his previous history of neutropenia was to repeat labs with a plan on immunology and hematology referral if it were to be persistent. So this is his CBC with differential. It is significant for an ANC of 380 at this time with leukopenia. His other cell lines are intact. The PCP at this point obtained some further labs as well. This included a vitamin B12 and folate level, which were within normal limits, an HIV screen, which was non-reactive, and a CMP, which was overall within normal limits. So regarding the overall differential for neutropenia, it's quite broad, and really regardless of the history of this specific patient, I like to think of the differential as divided into inherited or acquired conditions, with inherited including congenital neutropenia, which includes some immunodeficiencies, in addition to familial neutropenia and a phenol-associated neutrophil count. Inquired conditions are quite broad as well, which include different medications with some common culprits, infections, and an autoimmune umbrella, which includes anti-neutrophil neutropenia and other autoimmune disorders, in addition to nutritional deficiencies and hematologic malignancy and other heme conditions. It's also important to think of these patients as sick or not sick and to try to categorize them this way, with one example being the 10 warning signs of primary immune deficiency in children, which is not all encompassing of all immunodeficiencies, but does help us determine slightly the path of workup for these patients that may come into the office. In this case, this patient was sent to immunology. So further history obtained at this primary visit was that he was noted to have leukopenia when he was young. His birth history was overall unremarkable. It was a term delivery without complication. He did note that to have multiple family members with neutropenia without a history of infections that he knew about. A full infectious history was taken to help delineate humoral or cell-mediated immune deficiencies and was unremarkable overall for any upper or lower tract infections, skin infections, recurrent fevers, or hospitalizations due to infections as well. So it was discussed with the patient at this point, really, that in the absence of any infection, a comprehensive immune workup would be more low yield. But through shared decision-making, he did manifest an interest in pursuing some immune workup. So for his immune evaluation, he did have normal serum immunoglobulins, except for an elevated IgE, which is likely in the setting of his atopic disease. He did have a mild low total complement level, which was likely a sampling error as it was repeated and normal. He had a positive tetanus and measles titers. He had normal pneumococcal serotypes and did not need booster for further testing. He had normal lymphocyte subtypes and negative anti-neutrophil antibodies. He had a repeat CBC with differential at this point as well that had a stable mild leukopenia with a white blood cell count of 3.5 and a higher ANC than he had previous. At this point, it was 1390. And he had a CMP that was reassuring again as well. So at this point, and given these results, what do you think about his neutrophil counts, and would you send for any additional testing?
And you guys feel free to drop it in the chat or unmute yourself and give any ideas if you have any. If you're startled with how comprehensive it was worked up, we can continue, so don't worry. But if you have any ideas, feel free to let us know.
Sorry, it was Paul Gallo from Colorado Children's. So, did you mention, he's 24 years old. He hasn't like been hospitalized a whole bunch of times, pneumonias, abscesses, sort of, and all that sort of stuff is sort of pretty reassuring to you. Is that what it sounds like? And I guess the things I think about are, it seems like his neutrophils are working. Sounds like no gingivitis or oral ulcers that someone else says. Yeah, no, like
that's correct.
Mucositis sort of stuff. And with the family history, with a little bit of neutropenia, maybe, sort of everything's pretty sounds reassuring. Things I think about are like Duffy null, the nutritional things. It sounds like he's grown well and that sort of thing. I think of copper and zinc as well, so especially with kids who are pretty malnourished. And then what was the other thing I was thinking about? The SSRI, I wouldn't sort of completely brush off. The SSRIs can sometimes also cause neutropenias. Would be on my initial thoughts.
Yeah, 100%. I was just gonna tell on that one, Paul, that he he had not like in paper, but he had documented leukopenia and neutropenia since very early ages, so much earlier than the start of the SSRI, but definitely a good point.
You didn't cycle him, right? You didn't do like CBCs twice a week or anything.
No,
So
this
you don't
I
know.
meant just more historically from when he was a kid, from what parents told him on like a CBC with differential when he was a baby, but not like cycle to see.
Yeah. I mean, so that's reassuring, right? If it's been there for a long time and
Yeah,
he's been okay.
but it was a very good thought because meds
But
are
yeah, I would probably do cycle. Maybe he cycles and but his sort of his baseline is high enough where he's not having issues, but he might dip down. Be the other thing I would look for.
perfect. All right, Kristen.
All right. And just one other question. From initial presentation, what workup would anyone recommend as best practice based on this case?
So Paul already helped with cycling to kind of like see if there's a pattern to some of this neutropenia. And anybody else has any ideas additionally and what was done, or would you have done something else in the setting of this if he had seen you in clinic that you think it's missing, except for the cycling idea?
I think before we would put the patient through 6 weeks of 2 to 3 times per week counts, if we're worried about cyclic neutropenia, which I would say the history doesn't lend itself to that because there's not episodic oral ulcers or fever episodes or episodes in the family that are similar to that, because remember that is autosomal dominant, and no episodes of colitis, we would actually look at the monocyte count for reciprocal monocytosis to see if there's a hint. Obviously, it's easier to map that out when you have more counts, but you can at least get an initial judge as to whether the monocytes are sort of opposite of the neutrophils.
And his AMCs had been normal, Kelly, so that was
Yeah,
good.
so it's not really just cyclic neutropenia, it's actually cyclic hematopoiesis.
Mhm.
So you can see that the monocytes and the neutrophils are opposite, but also the platelet cycle. So if you're seeing anything that matches, that might be an easy go. But we probably would have had a fairly limited approach to diagnostics for this patient.
Similar to this, anything else you would have done on the hematology side of things, lab-wise?
Yeah, we would have ordered a Duffy. And since there's no rheumatology symptoms, like we would have considered some of the rheumatologic screens, but in the absence of symptoms, we probably would have started just with a Duffy.
And he had an ANA only with PCP. That was like a 1 to 40, but without any reflexes coming. So that was the only thing at this point as well.
Yeah.
All right, great ideas.
All right, great ideas. Because we did order a Duffy null status at the same time as his immune workup. That was based on his family history, ancestry, and really overall clinical picture without recurrent infections and an overall unremarkable physical exam. And this was positive. So one other interesting aspect of this case is that the patient in parallel was also scheduled to see hematology at an outside hospital for evaluation of this neutropenia. The workup is shown here, having been sent previous to our Duffy null status. This included kind of significant workup with flow cytometry, another neutrophil antibody, vitamin A and E, T cell receptor beta by PCR, and further testing in addition to a genetics referral. All of these results were negative. However, his flow cytometry and PCR did end up raising concern for T cell LGL due to a small, large granular lymphocyte population that showed clonality on PCR, which is described below. So his case ended up being discussed by tumor board as it was unclear if this was a reactive or neoplastic expansion. And there were a lot of discussions back and forth from what I saw on if he needed a bone marrow biopsy. So he ended up not getting the bone marrow biopsy, and their overall plan was to repeat the flow that was normal without any clonality. So Dr. Merz is our speaker. She's an expert on this topic of Duffy null-associated neutrophil count. She'll go into much more detail, but just for a starting point, the current definition of neutropenia is an ANC less than 1,500, and that's the reference range at our hospital. However, it is estimated that 25 to 50% of individuals of certain non-white ethnicities, they do have ANCs that would qualify as neutropenic based on this definition, but don't have any associated negative effects such as infections, or otherwise. And their neutrophil count may be a typical neutrophil count with the presence of a Duffy null. And these individuals, as we could see, go through extensive hematologic and immunologic workup sometimes. It has been shown that there is an unnecessary cost burden for these individuals as well. And it's also important to consider the psychological burden of this extensive testing. And going briefly back to our patient, he was noted at a PCP follow-up to have an increase in his stressors that did cause worsening mood for him and actually did require transition of his medications, which has since shown improvement from what I saw. He ended up being cleared from all specialist care and just to be needing to be seen as an as-needed basis without any further lab testing that was recommended. And he's continued to do well without infections or other relevant clinical history. So if there are any further questions or comments on this case, otherwise, I'll turn it over to our expert speaker, Dr. Merz.
Kristen, I'm going to try to share my screen while we're seeing if anyone else has questions.
I'm going to stop sharing here.
Can you all see that okay?
Yep. Still
Okay.
showing. Yep. Great. Now it shows presenter.
Great. Okay. Before I launch, any questions about the case for Dr. Mikhail? Cool. Okay. Well, I am really excited to be here to talk about some of my thoughts or approach to the Duffy null variant and absolute neutrophil counts. I will also just start by acknowledging that I'm an adult trained physician. And so a lot of times our frame on things are a little bit different than I know that we have to think about in pediatrics. We also have more data in adult patients right now. And so for those reasons, it might be a little bit more adult focused. And I also want to acknowledge that by the time that people see me as adult patients, they have at least 18 years of life to prove that they're okay. And so I know it's more complicated when you're seeing a 2-year-old or a 10-year-old to figure out if they might have some sort of immunodeficiency or other issue compared to just maybe being within the realm of normal. So that'll be some of the frame in which we have this discussion. I would love to be interrupted if anyone has questions along the way in trying to make this as applicable to your day-to-day practice as we can. So with that, quick review of neutrophil development, because this does impact the way we think about our reference intervals. So maturation occurs in the bone marrow and takes about 7 to 10 days to complete in total. And the thing I really want to highlight is that only 1 to 5% of your total body neutrophils are circulating in the bloodstream. And the neutrophils that you do see are only there for 3 to 24 hours. I know many of you know that neutrophil count in the morning is often lower than neutrophil count in the afternoon, right? Some of us who have accidentally gotten 2 CBCs of differentials back to back, especially on an inpatient setting, right? We've all had that accidental episode. You'll notice there's big variation in the white blood cell counts that you do not see replicated in the reds or the platelets. And so when we analyze an ANC from a CBC, we have to acknowledge that this is a brief snapshot that can fluctuate within hours. And it's also an imperfect proxy for total body neutrophil count, which actually matters for mucosal integrity and immune efficacy. We also have learned, I think, in medical school, and it gets solidified again and again, these clinical decision limits that are supposed to help us identify disease. I think a lot of us learned that a mild neutropenia is 1,000 to 1,500, moderate 500 to 1,000, and severe less than 500. And there's some associated infection risk associated with that. But where did that come from? The best I could tell, it actually came from chemotherapy toxicity that was assessed in the 1980s. And so this was predominantly based on men. And it was a collaboration that predominantly included people of Asian or European genetic ancestry. And again, this was a time where we had myeloablative therapy and was supposed to try to be our warning signal for when there might be risk for infection. So then we have to ask ourselves, do these thresholds work when they're routinely applied to all causes of neutropenia, especially causes where the bone marrow function might be intact or other reservoirs might be intact? So again, an example of this where these criteria work and have been validated and used is things like myeloablative chemotherapy, right? You have apoptotic cell death, these severe infections. It's going to take like 7 to 10 days to recover. I also then wanted us to think about another idea of things like autoimmune neutropenia, right? The bone marrow function is still intact here. You have other reservoirs of neutrophils. And I see a lot of patients in my clinic where they have a baseline ANC of somewhere from 200 to 1,000, and they do not have any increased risk of severe infection. So again, the numbers might be the same, but the risk of infection or how we evaluate these things needs to be pretty dramatically different. So I also want to think about another way that we define neutropenia or we identify health, and that's through a reference interval. It's intended to capture the central 95% of a population, but I want to point out that the more I got into this, it only takes 120 samples to develop a new reference interval, and to validate it, it only takes 20 to 40 samples. And so as you can imagine, this is often a convenient sample and may not be fully representative of all the diversity of the patients that we're serving. So for example, I work at these 3 hospitals that are listed here, and they all have very different ANC reference intervals. Dana-Farber has a lower limit of normal of 2,200. Physically connected and across the street at Brigham and Women's, the lower limit of normal is 1,900. A few miles down the road at Boston Medical Center, the lower limit of normal is 1,800, right? So a lot of variation there. When we look in the United States and things like NHANES, which are large data sets that allow us to kind of assess health for people, we do see that by race, there is a difference in ANC, with Black race having about 700 cells lower than white race. And when we use that definition of neutropenia, 0.79% of white folks will have this, but 4.5% of Black folks will have a neutropenia despite being otherwise healthy. Really important for me to emphasize here that race is a social construct and not a biologic fact. We use this as a proxy for a very, very long time because we didn't have other genetic or genomic information. But we have that now. We've had that pretty reliably for the past 25 years. And so there's more genetic variation that will be biologic drivers within race than between race. So really important to emphasize that. We finally got our answer for why we were seeing differences in the absolute neutrophil counts by race with the understanding of the Duffy genotype. So this is a T to C substitution at the gene transcription site at RS2814778 on chromosome 1. In the homozygous polymorphism, CC results in the lack of Duffy expression on erythrocytes. You still get expression on other tissues, just not erythrocytes. And when you account for the Duffy genotype, we completely lose the association between race and lower ANC. So it really is Duffy that is the driver of the lower ANC, and it has nothing to do with the amount of melanin that's in your skin. This was thought to be protective against Plasmodium vivax. If you take away that antigen, there is not that docking port for the parasite to enter and cause disease. Since that was likely the reason or the driver, we do see the Duffy null variant in areas where that would be most beneficial. So you see about 80 to 100% prevalence in West Africa. When you go to the Arabian Peninsula, it's about 50% or higher. And then in the United States, among people who identify as Black or African American, you can expect 2 of every 3 people to have the Duffy null variant. In contrast, less than 1% of people who have genetic ancestry predominantly from Europe or Asia will have the Duffy null variant. So we're talking about a red blood cell variant, but how does that end up impacting our neutrophils? We think that it actually comes back down to hematopoiesis, where there is interactions with your hematopoietic stem cells. And so it results in neutrophils that have altered surface markers and an increased propensity to leave the circulation. There was a really beautiful mouse study that I've tagged here and used this figure from, where they tagged the neutrophils and actually found that they go to the spleen over the other reservoirs, like the lungs or the bone marrow or the liver. And so what this tells us is that the total body neutrophils are unchanged, but localization, what we're actually able to measure when we get a blood draw, is the thing that's altered. This is emphasized that Duffy is a normal variant, no matter how we look at it. So we've done really large studies on things like infection risk, whether it's bacterial, viral, type of infection, and we see no difference by Duffy status. We also see that there is appropriate number and response and function to stress, GCSF. We've also had a lot of patients that have gotten bone marrow biopsies, and we see that bone marrow pathology is unchanged, and you cannot tell the difference between a Duffy null and a Duffy non-null bone marrow specimen. So that kind of brings us to the question of, okay, what is a normal ANC for someone with the Duffy null phenotype? We actually didn't know for a very, very long time. This is a study I did while I was in residency with adult patients at our primary care clinic, where we asked them if we could add on an ANC and Duffy testing to any blood work they were getting for routine care. We poke adults a lot, so it's things like, when they're getting their A1C checked or their cholesterol checked. And we found that 2/3 of our Black patients were Duffy null, and of those, nearly a quarter had an ANC of less than 2,000, and 10% had an ANC of less than 1,500. In contrast, 0 subjects who were Duffy non-null had an ANC that was below our institutional threshold. And in fact, there was no significant difference between the median ANC of our Duffy non-null cohort compared with our institutional cohort. Just putting some numbers on this to think about our practice. If we have 2/3 of Black individuals that are Duffy null, that's 27 million Americans. And if 23.8% have an ANC of less than 2,000, that's 6 to 7 million Americans who will have an ANC below typical hospital ranges. And if 10% have an ANC that's less than 1,500, that's 2 to 3 million Americans who will be inappropriately given a label of neutropenia and perhaps be at risk for things like being referred to hematology or allergy and immunology and getting extra testing done, kind of like the patient that Dr. Mikhail presented. So based on this, we did develop adult reference intervals for those who are Duffy null. And we recommend that a Duffy null reference range, lower limit of normal should be 1,200 with an upper limit of normal of 5,400. This has been in use at Brigham and Women's Hospital and the affiliates for 3 years now. And we are currently working on pediatric ranges. We do not have those yet. The data that we do have with some pediatric ranges comes from work I did in medical school, Dr. Walkovich, where we looked at patients who were referred for neutropenia testing to the pediatric hematology clinic at Michigan. There were 27 healthy patients who were found to be Duffy null with nothing else wrong with them. And we looked at it in 2 ways. So in the graph that you see on the left, this is in the black triangles, all of the healthy ANCs of Duffy null patients. The white circles are age and sex matched controls. The gray shaded are the institutional reference intervals. And on the graph on the right, you can look at the lowest healthy ANC of the Duffy null pediatric patients that we were able to obtain. From this, we determined that in the right clinical context, which again means that you've ruled out the bad, scary, dangerous alternative reasons for neutropenia, people with the Duffy null phenotype who are 3 or younger may have an ANC as low as 100. And individuals who are 13 or older may have an ANC as low as 500. I will say that the 13 and older is definitely replicating what we see in adult data as well. We do see patients as low as 500. It's rare for us to see anything below that. But again, more work needs to definitely be done in the pediatric space.
Question for you then.
We're working on it. Oh, sorry, Dr. Gallo.
Yeah, no, call me Paul, please. But I'm very curious at your answer of this then. What about just one Duffy minus?
Sorry, you were breaking up there. You said chest 1?
Just one Duffy is mine.
Just one.
Like if Duffy,
Yeah.
you see differences with just one null and not both null.
So we have not, in adult populations, I can say very confidently that we do not see any significant difference in ANC between those who are TT, so like homozygous positive, or whether they have one copy of C, whether it's on the FYA, FYB. So those, there is no significant difference. We looked at that in our prospectively collected data from Boston, as well as cohorts in Namibia, Saudi Arabia, and big biobanks, including the Mass General Brigham Biobank and the UK Biobank. No difference in ANC in adults if you are have any of the T alleles. As soon as you are CC, that is where we see a difference. So we do kind of batch those 3 genotypes into Duffy non-null, and then we call, the CC Duffy null, and we don't care if you're heterozygous or homozygous positive, since it does not seem to impact your neutrophil counts.
Interesting. Got it.
Yeah. Maybe we'll find something different for that in peds, but I wouldn't expect it based on the patterns we're seeing in adults.
Got
it. So we are working.
Can I ask another question?
Of course.
Hi, Hi, I'm Michelle Brenner. I'm at Medical College of Wisconsin. I'm one of the third-year fellows. From the pediatric, so obviously I see pediatric patients here at Children's. And so from the pediatric data that you had, did you follow that over time to see if any of those were like they had Duffy null and maybe autoimmune neutropenia that we see kind of in some of these timelines? Because that's always a conundrum we seem to face as well.
Great question. So this cohort was really rigorously defined. So anything that may be impacting neutrophil counts, they were excluded. So we did actually exclude any patients who had the autoimmune antibodies tested and were positive. There are people included in this who didn't have that testing, but I will say since most of them were referred to hematology for testing, that is usually like a first batch of treatment. So I can't remember the exact percentage of how many had the antibodies tested and negative, but I want to say it was close to 80%. And anyone who was tested and positive was not included in this cohort. This was like not a whiff of anything wrong with them. Like even people who like fell off their growth curve or had like a label of failure to thrive, not included in this cohort. We wanted it to be, it's a small cohort, but we wanted it to be like really clean to try to see, you know, what is the lowest of the low from Duffy alone.
Perfect. Thank you.
Great question. Okay. We are working on it for peds. So we're in the midst of a grant with the Doris Duke Foundation through the American Society of Hematology, where we're validating the adult reference intervals, and we're also trying to develop Duffy null pediatric ANC reference intervals. We will have it by 4 different age cohorts, I believe like 2 weeks to a year. I want to say like a year to 6 years, 6 to 12, and then 12 to 18. Don't quote me on those exact breakdowns, but trying to capture the variation that we know is going to happen within development. We will not have it for like, you know, infants. That's just going to be a little too challenging for our cohorts, but we are hoping to at least have a better sense of what we can expect, because again, that's going to drive a lot of our care. What is normal? What can we expect for our average patients? Again, this doesn't take a lot. Once we have a published range, you only need 20 subjects that are within the reference interval to validate it. So once this is published through ASH, which again, we expect to happen, hopefully for ASH 2025, we'll have a abstract that we'll be able to present and then a publication shortly afterwards. Your laboratory could potentially even just get 20 Duffy null samples to validate it. And so it really is a lot easier than we think it is. And so a lot of opportunities for systems updates here as well. So stay tuned for that information. I know it can be a little dry because it's like as reference intervals, but I do want to emphasize what I know you already know is that it does matter for our patients, and we do see differences in the kind of care that's provided. So this is adult patients, and this is a study that looked at bone marrow biopsies for a neutropenia workup. And for 95% of Black patients, there was no pathology identified. And then 60% of Black patients got a final diagnosis of clinically insignificant neutropenia, which again, we can assume may be due to the Duffy null phenotype in 60% of patients compared to only 9% of white patients. So there is a disparity here. Another study looked at a similar thing for bone marrow biopsies for isolated low white blood cell counts, and 97% of the patients had the Duffy null phenotype. And of those, 94% had a stone cold normal bone marrow biopsy. Any of the abnormalities that we saw there were the adult things that we've been fussing about, like, you know, CHIP or like minor dysplasia. So it wasn't like an MDS or, you know, anything like big or major, just wasn't stone cold normal. In pediatrics, there was a really interesting study that out of the Detroit area that found that 64% of referrals for neutropenia were eventually given the diagnosis of benign ethnic neutropenia. That is language we're trying to move away from, but the language used in that study. And 77% of these cases were confirmed as having the Duffy null variant. So again, a big impact on our resources, on our patients' resources, and potentially unnecessary. We also know this is impacting clinical trials. Again, this is adult clinical trials in oncology. And the long story short is that 75% of trials are at risk of excluding patients with the Duffy null variant. We're seeing this is actually applying to patients, like real world patients right now, but this is from just looking at the protocols themselves. We do see a very similar story in pediatric trials too. And the biggest culprit is actually industry trials. And so really paying attention to that is going to be important going forward. Another thing I want to mention too is that this is again an adult study, but looked at azathioprine for autoimmune conditions and looked at rate of discontinuation due to hematopoietic toxicity by Duffy status. So if you look at the white line, or the blue line here, that is white patients, all of whom are Duffy non-null. The red line here are Black patients who are Duffy non-null, no difference in discontinuation. However, when you look at Black patients who are Duffy null, there is a significantly higher rate of discontinuation for azathioprine. So again, impacting the critical medications that we're able to give people. We assume there's probably a similar story in pediatrics as well, especially because this same study used a validation cohort of African-American children with ALL who were treated with 6-MP, which is a metabolite of azathioprine, and showed that Duffy null children had lower weight-based dose intensity compared to Duffy non-null children. So again, more work to be done in this space, but definitely something to think about. So then that brings us to what do we do, or what would maybe I have done if I had seen that 24-year-old patient in my clinic. What I tell everyone is, because Duffy null is so common, Duffy null people can still get other issues. You are going to have Duffy null patients who have primary immunodeficiencies or leukemia or autoimmune neutropenia. So it is still critical to evaluate for all these things clinically or through labs before feeling confident that you can assign a neutrophil count to the Duffy null phenotype alone. So what I do in adults is typically rule out a medical emergency of febrile neutropenia. I then do an assessment for leukopenia or leukemia if that has to be an urgent referral. And then the rest of it, I suggest going to an outpatient setting. And I think about things either clinically or laboratorily, such as dietary issues, viral infections, autoimmune disease, new drugs. I know this will be a slightly different setup for pediatrics, but kind of a similar idea. You know, what do you need to do urgently versus what can you do in a clinic setting through either clinical assessment or labs? The one thing I would add, which I know Dr. Mikhail went over too, is thinking about primary immunodeficiencies. This is for the adult patients that we think about. But again, usually by the time people see me, I feel pretty confident they do not have an immunodeficiency because they've had decades of life to confirm that. Duffy testing is actually pretty easy to get. There's two ways to do it, either phenotyping or genotyping. Phenotyping is very similar to getting a type-in screen. So if your lab can do that, they almost certainly can get you Duffy status. Both must be negative to be consistent with the Duffy null phenotype, your FYA and your FYB. And it only costs about $10. It's reimbursed at $12 by CMS. So very accessible and easy to obtain. Genotyping is about 10 times more expensive. You can reduce costs if you batch it, and it's not as widely available. I think most laboratories are doing send-outs for this. Last, I just want to mention that, you know, a lot of us may have learned the phrase benign ethnic neutropenia. That's how I learned it. There's actually the thing that first drew me to this topic is that just felt like such a crazy name, that we had something that wasn't a condition. We had something that only had a definition because it was not what we saw in our white patients, right? And so that othering and the name ethnic and neutropenia just didn't sit right with me. But we still want to be able to communicate clearly with our patients and with each other. So we have recommended changing benign ethnic neutropenia to the Duffy null associated neutrophil count. We think this relies more heavily on the biologic association and also emphasizes that this is a normal, healthy state, that it is not a condition or something to be concerned about. We did get this approved for new ICD-10 codes. They're in the Z section, which is very similar to how you would document things like RH status. And they have been available for use as of October. So please document your patient's Duffy status when you do know it, because that will help us with you know, any future efforts with pulling in a specific reference interval and future research as well. That's all I have, but I look forward to any questions or discussion with the time we have left.
Excellent, Lauren, and excellent, Kristen. I'll let everybody ask questions, but I have just a provocative one for you that I don't know you have the answer for. But because this touched so many topics on rearrangement of equations and particularities of self-identified race and ethnicity, etc., how do you envision, it's admittedly provocative, but how do you envision the funding for this area to continue in the next few years with some of the stressors and changes that we've been seeing going around. And feel free to play the
Yeah.
if you don't want to talk about it.
No, this is something I've been talking about a lot. And we actually got a lot of questions from the 24 institutions we're partnering with when the executive order first came out of like, hey, does this count under the executive order? What I have been telling people is this is a genetic variant that just impacts what normal is. And it's, so it does not have to do with diversity, equity, and inclusion. Now, that's not how I actually feel about the research, right? I got into this because of the justice aspect of it and like wanting to be more equitable. But the reality of the world that we're living in right now, I am framing it more as a like, no, we're assessing a genetic variant. It is a genetic variant that you're going to see most often in people who self-identify as Black, African American, Middle Eastern, or North African. But I'm just kind of leaving that out when I am writing grants and papers recently in order to get the work out there. And yeah, that's a more existential debate too, because again, a lot of my other work is also in women's health, and I just submitted a K on sickle cell and maternal outcomes. So same idea of how do you talk about genetic variants versus race when really these two things are overlapped, but kind of distinct entities. So continues to be sticky both in how we talk about it in this political climate as well as how we talk about it as researchers, right? Acknowledging that you're going to see Duffy null more in someone who identifies as Black, and so that might be a triage point, and that's okay to have it as a triage point, but that can't be, your end all be all of I'm assuming they're Duffy null because they are Black. So kind of like cuts from both ends.
That's great, thank you. Yeah, and I thought of even with the clinical correlations that you're saying, thought about it in the way of like coverage from insurances and CMS, et cetera, if it became like a pain point where this was like removed from coverage because the powers that be wouldn't want it to be covered, et cetera. But your answer is really good as well. Thank you.
Yeah. And we're mostly just trying to truthfully emphasize that it's a genetic variant, right? And so when like all genetic variants are going to run in certain patterns, and we just don't need to emphasize what pattern it's running in because we want to be able to help our patients the best we can. And I think that's going to be the way to be as protective as possible. I think I just saw a question. Let's see, can Duffy status cause just leukopenia with an ANC being greater than 1500? So yes, I think too, it's I am trying to slowly move the way we think about Duffy null from, again, in the past, there's always 1500 or lower, benign ethnic neutropenia. We are using, DANC or DANC as like, 1500 or lower, but I'd actually recommend expanding the spectrum of how we think about it. And instead of being like, oh, 1500s are abnormal, thinking about the range you expect someone to be who is Duffy null versus Duffy non-null. And so like, yes, someone can have the Duffy null phenotype and have an ANC greater than 1500. Again, the range in adults is 1200 to, 5400. Usually you don't see as big of an effect on the white blood cell counts. We have a publication that's under revision at Blood right now, so keep your fingers crossed, where we are also putting out some white blood cell reference intervals by Duffy status, which hasn't been done yet. And again, there is differences, but it's not quite as dramatic as what we see in the neutrophil reference intervals. So and the one other thing I would mention too is that I think we thought of reference intervals as very concrete things, but the more I talk with pathology, the more I realize that we have to think of them as suggestions or starting points, and then we have to see if that actually applies to our individual patient, or look at the person in front of us. Are they sick or not sick? And then care about the neutrophil counts. I think a lot of times, especially as we're training and first developing our gut, we anchor so much on the neutrophil count itself that we forget to actually look at that patient and make that determination of sick, not sick. And so just advocating for reversing that order. First, just look at that person in front of you and, make a clinical determination, and then look at the counts itself and try to think how that might fit into the puzzle and fit the person that's in front of you.
Lauren, I thank you for your comments and everything. I think learning from you, I've been inspired, even though I've been around a long time. In our immunohematology clinic, there are certain things that we see over and over again, and Duffy null is a big one that we end up sending a lot of the Duffy testing for. We are now moving from more panels and exome sequencing to whole genome sequencing at a pretty rapid clip right now. And I've started the conversation with some of the big testing laboratories to report out this polymorphism because of the clinical implications for it. So I hope that some of the big labs will pick this up and report it out, because it can help in the overall care of the patient that we see. Just like in immunoheme clinic, where we started adding on filaggrin for people with high IgE counts and the atopy predisposition. I think this is another thing that can help us out in the assessment of our patients.
Yeah, no, it's a great point. And I think too that I want to emphasize that, you know, our first step is just establishing normals, which we've gotten pretty good at with adults. We're on our way with peds. And then after that, it's how do we use these, right? We've worked so hard at developing these reference intervals, but how do we use these? And I think things like, you know, if you have whole genome sequencing and you have these SNPs reported, I am working with 23andMe right now. They want to report out more Duffy status too, so people will know through commercial mechanisms. That's why we advocated for these ICD-10 codes, right? So people will just be more aware of their status. We're working on things like cost effectiveness analyses of, you know, could we do universal testing? You know, would we want to pick, you know, certain cohorts of people? So that is kind of step two is, you know, we built these things. How do we implement them and make them work for patients, make them work for people who are trying to analyze an ANC and decide if it's normal or abnormal? And then the third step, just to project that too, is applying it to how we do clinical decision tools or medication doses, right? I referred to some of that with ALL and the azathioprine, clozapine for schizophrenia is another big one too. And so we do have to kind of work on these simultaneously, but some of them are dictated in a stepwise fashion. So again, I think we're nearly done with step one and encouraging that to be taken up more rapidly. But then the most urgent and pressing step two is, okay, well, if these exist and if labs are on board with them, you know, being implemented at your institution, you know, how do we get that out to providers? How do we get that to patients? How do we get patients to know their Duffy status? So that is some of the questions that we're working through right now. Oh, sorry, I missed. There's an editorial personal comment from Kristen. Once the U.S. returns to carry about DEI, I'd love to see a review article on all the discussion points we missed in the literature during this disturbing period in history. Yeah, would hate to miss brilliant thoughts of those doing the work that feels silenced. Thank you for saying that. Yeah, it's been, I'm sure a lot of you fall into this boat too of, it's a weird time to be a health equity researcher where you want to make sure that you're loud and proud about the things that you care about, but you also want to make sure that you can still get the grant funding so you can still do the work for your patients and that there isn't a total pause. And so, yeah, trying to find that line between being authentic and true to the science and, you know, true to my patients while also still trying to get awarded so I can continue doing this is a tough balance that I've not found the right answer to. But I appreciate the encouragement and the how steadfast the scientific community has been. And that's really been, I think, getting all of us through.
Thanks, Lauren. Should have been helping you with that chat, but I was reflecting on everything you were telling us meanwhile as well. Does anybody have other comments or questions?
Yeah, hey Lauren, it's Kristen. I was just going to ask, you mentioned kind of validation at the individual institutions. It would be absolutely lovely to have a practical how-to guide for all of our institutions once the data is available for adult and peds. Like, here's the data, here's what you need to do. Like, how can we advocate for that? I think I would love to be able to push for something like that when it's available, but knowing how, you know, it's not something I readily do.
Stay tuned. January 2026, we expect these guidelines to be out. We are hoping for kind of a simultaneous publication of our adult reference intervals, the pediatric reference intervals, and kind of a how we did it guide. I actually have a meeting tomorrow as the kickoff for the writing of this, and we're doing things like identifying this key things for success. And so some of our outlines are like, who are the stakeholders you need to talk to? You know, how do you identify the right population and then get the blood from them? What's the best way for testing testing, both, logistically, cost-wise? How do you work with your EMR and IT to actually get these ranges into your electronic healthcare records and educate? So we are kind of planning a how to do it roadmap with specific examples from 7 institutions that are ranging from California to the Northeast to academic, community, pediatric, adult. So trying to get a whole range of experiences and resources available too. So hopefully it's something that most places could take and replicate without having to completely reinvent the wheel. So it's not there yet, but it is coming. I also want to highlight too, there is a lot of really cool Duffy null resources that ASH has helped us build. So if you just Google ASH Duffy null, it should pop up. There is infographics, things for patients, one-pagers that are intended more for primary care. That's where I got the graphic about the neutropenia assessment of red, yellow, outpatient. Again, it is a little bit more adult focused right now, but Kelly has just agreed to help us with a pediatric focused one. So stay tuned for that. That's a great resource kind of for the in-between until we get that roadmap out to you, hopefully in a few months.
Perfect. I love that. Thank you.
All right. If no one else has more questions or comments, I'll let you guys out a couple of minutes early. Thank you so much again, Dr. Kristen, Mikhail, Dr. Lauren, Merz, for a great session. And you guys stay tuned for all of this because we really hope to see this to fruition. Thank you. You all have a great day.
Thank you for having me.
Thank
Bye.
you.
Thank you.